Good afternoon, good morning, good day, wherever you are. Thank you for joining us today. We've got a great executive insight here with Sean Hansen. AI in action, enhancing patient-centered healthcare. Before we get started, I'm just going to give you a little overview of our executive business programs here in the Saunders College of Business. Some ways that you can interact with us are our custom programs, where we work with organizations, their learning and development teams on different topics. I'll show you in a minute. You can do our EMBA program and also work with us on our capstone projects. So this is our team. We got our co-directors, Molly and Rick. Jesse's our program manager. Jancy's online with us today. And then Julianne works on our admissions. So some of the topics that we work with organizations on: strategy, innovation, leadership. So your change management, your negotiations, your managing innovation. We've been helping a lot of different companies with those topics recently. If you choose to go through our EMBA program, you're looking at a 16-month cohort-based program where we cover business core with some leadership and tech focus here. And you also can choose between global business or life sciences for the electives. We're really big into experiential learning. We do trips and business simulation, and then these are delivered online or in a hybrid format. I am now collecting capstone proposals through April. So if your company is looking to enter a new market or generate some new revenue streams, I'd love to talk to you because our EMBA students will be happy to work on that project for you. So, Mr. Hansen
Doctor, you got to give
is,
me the doctor now.
yes, Dr. Hansen is our department chair here at MIS Marketing Analytics here in the Saunders College of Business. He's professor of management information systems. His research interests are in software design and development, health IT strategy, and the application of contemporary cognitive theory to information systems development. So prior to embarking on this journey in research and teaching, Dr. Hansen provided a management and technology consulting services to companies across the industrial spectrum. He regularly presents his research at leading academic conferences, and he has received his PhD and MBA from Case Western Reserve and an AB in psychology from Harvard. So, with that, I give you Dr. Sean Hansen.
Thanks. No, I appreciate it. I was just kind of kidding about the doctor thing,
Yeah.
particularly since we're going to be talking about healthcare, if I have physicians on, rest assured, I don't actually usually emphasize the doctor piece. I want to do one quick, before I start sharing some of my notes, I want to put one quick plug in for what Noah just mentioned. Those capstone projects, if you have organizations, if you're operating in organizations where you have a question that you'd really like explored in depth, having taught in the EMBA program for most of my 15 years here at RIT, I can tell you those capstone projects are very professionally executed by an incredibly talented team of executive MBA students, candidates, and they really generate some fantastic insights for organizations. So if you have a challenge that you would like some smart people to look at, please reach out to Noah. You will see, I'm going to go ahead and start sharing my notes or my presentation slide for today. But I want to note that I have slightly changed the title. We're still, oh, that's not what I want. Duplicate, that's good. I thought it would be valuable since every presentation you've probably been in for the last 2.5 years has focused on AI. I wanted to be a little broader than just AI in this discussion and sort of talk about some of the key trends in health information technology in general. It's very true that AI is a subtext for a lot of these. I saw that some of my current students are on the current call, so it's the same thing I said yesterday, that it's in my class yesterday. AI is sort of a subtext running underneath a lot of IT investment and advancement currently. And sometimes I'll call it out explicitly, but some elements of IT, health IT investment are not, strictly speaking, AI dependent. Are you guys seeing this? I'm getting a weird message that says, please move this window away from the shared application.
We can see the first slide.
Okay, all right. All right, cool. Side note, since we are talking about this in healthcare, what I'd like to do is a quick poll, and Jancy, if you could execute it, I would love to know how many of the folks on the call are currently working in the healthcare space, and that doesn't have to be, you don't have to be a provider, any facet of the healthcare domain. I would say give it a yes. So I would love to see the answer on that, because it can help me to sort of tailor my notes or my thoughts, and also give me a sense of some of the questions that we want to make sure we get to. So I suppose I should answer it as well. Or maybe I can't. Oh, hosts and panelists cannot vote. The other note, after the poll, I would love, and I know with webinars it can be a little tricky, but I would love to make this as interactive as possible. So if you want to submit questions in the chat as they occur to you, I know Noah and Jancy are going to be monitoring that, and maybe I'll just pause periodically and say, and ask if there are questions out in the discussion that maybe we could address or talk through. Should I keep going?
Yes, I can also share the poll
I can
results
close
if you like.
Okay. Oh, do you have it?
I do. So
Okay, yeah,
on
sure.
our call today, the majority do not work in healthcare, but 32% of the no work with the healthcare industry, but 27% of our attendees are in the healthcare sector.
Okay, cool. I one of the unique things about healthcare is it is a field that touches us all. So not even just in a business context, we all have to take advantage and seek the services of the healthcare system, and that's actually one of the reasons why I think it's a critically important discussion as new technologies are adopted within the field, that we at a societal level sort of understand those and talk through those, and just get a broad discussion of the impact that it has on the way in which care is delivered, since it really does touch everyone. So just as a little preface, investment in health IT is incredibly high right now, which is kind of interesting because traditionally healthcare was sort of a lagging field in terms of general purpose IT investment. So enterprise systems have been a wide focus of IT enterprise systems, meaning large database platforms or software platforms that integrate an entire organization onto a single platform, have been a key focus in a lot of organizational life since at least the mid 1980s in a lot of industries, certainly in manufacturing, in a lot of service industries, but that was not the case in healthcare, which various people attribute to different things. But one of the things is that physicians and care providers had a lot of leverage to maybe resist IT adoption in some earlier waves, and all of that changed in 2009. The passage of the HITECH Act, so HITECH, which is Health Information Technology for Economic and Clinical Health, was a act within the broader American Reinvestment, and I'm forgetting what the act was in 2009. It's the one that is often referred to as the Obamacare Act, right? So this was the focus on reshaping the health system, and the HITECH Act was embedded within that. And HITECH created a number of incentives for hospital systems, private practices, healthcare providers writ large, to invest particularly in electronic health records or electronic medical records. There's a slight variation in the meaning of those two. I tend to use the EHR, or Electronic Health Records acronym, into those systems. And so adoption from 2009 to 2000, about 12 or maybe 14, was dramatic. So it went from a fairly small percentage of health systems across the country having large electronic health records platforms, which is a form of enterprise system, like I just alluded to. So it's supposed to integrate an entire organization onto a single platform. Went from sub 20%, I think, in pre-2009 to well over 90% by 2014. So there was this real transformation with some incentive structures at the federal government level for that adoption. And in the time since, the investment in health IT has just continued to accelerate, largely building off of those electronic health record systems, but adding new functionality to really drive digital transformation of the healthcare space. And I think we've seen a real shift to that digital transformation in the last 5 years. So investment in health IT remains very high right now. Most recently, then, leaders of healthcare organizations and the IT leaders, the CIOs within healthcare organizations, are polled on a regular basis. And their most recent investments, I think it's worthwhile to say, what are the key objectives of this health IT investment? And while quality of care and patient outcomes tends to get top billing for good reasons, a lot of the focus in recent years is on increasing operational efficiency. We know that the healthcare sector, particularly in the United States, has had a cost crisis, right? Costs have continued to skyrocket for more than a generation now. And so a lot of organizations are saying, how do we operate more efficiently, get costs under control, and improve productivity of individual employees, all in the service of improving the quality of care that we can render to patients, and also innovating a little bit in the services that we can provide. So all of those are the objectives, but that is sort of the list in order of what a lot of these leaders have been emphasizing in recent years. So I want to just talk through a couple of the key innovations in each of under those various objectives. So the first one, care-oriented efforts. This is both improving quality of care, but also improving the experience for people within the healthcare system. And that means the experience of patients, but it also means the experience of clinicians, clinical care providers. And I should say, with that rapid adoption that I just alluded to, a rapid adoption of electronic health records over the last 15 years, has come a lot of pressure on people, on care providers within the system. So there has been a consistent mantra of, physicians and other care providers, nurses saying, I feel like these technologies are making me into a data entry clerk, where, I spend half my time typing into the system rather than just having FaceTime with my patient. And that has created, and also you frequently hear clinicians talking about how they have to spend an extra hour or two at the end of every day finalizing notes, making sure all the records are up to date. And so it's created this extra work burden in many ways that has led to burnout and high rates of turnover in some occupational categories. And so the experience for patients has been challenged, because patients will often say, I want my physician to talk to me. I don't want the physician to just be tapping on the keyboard and conducting a survey. So that's a challenge on the patient side. And again, as I noted, on the provider side. And so a big focus right now is, how do we improve those experiences for everyone? And there's a number of innovations that are sort of aimed at that. So one that has gotten a lot of attention in recent years is what's called ambient listening. So this is using AI to record and capture the patient client or the patient clinician consultation. So now, hopefully, the physician doesn't have to be tapping away on the keyboard, or nurse, or again, I'll use the phrase clinician to capture the whole category of clinical care providers. They don't have to be tapping away on the keyboard. The artificial intelligence tool can basically capture the consultation and generate a properly formatted note. If you ask any physicians, and again, we could maybe see if we have physicians on the line, that's a huge benefit. Again, because capturing the note, making sure it's documenting all the things that were discussed, is a significant data entry task. And if we can do it without a lot of human intervention or in a labor-intensive way, that's a tremendous benefit for the clinician, but also again for the patient, because the patient then is getting that face time and the real human interaction with their care providers. We also have now the promise of what is increasingly labeled precision medicine. So this is using algorithmic tools to identify unique characteristics of the patient, genetic characteristics, phenotypic characteristics, details of the patient's life, to fine-tune the provision of care to make sure that it is uniquely fitted to their individual needs. This is still sort of evolving in various ways, but I think the promise for care that is really targeted to your needs is a huge support. And then lastly, in this category, we have enhanced clinical decision support. So this is embedding, again, algorithmic tools into the electronic health records systems to mean that the clinical care providers are getting recommendations, suggestions, indications of things they should attend to based on the interaction with the patient, detecting patterns that suggest maybe we should consider this. It's also things as simple as presenting research to a physician, or again, a clinician. So, based on the characteristics of the patient and the conversation with the patient, the AI systems can say, here's some new research that has just emerged that you might want to attend to, or that might be relevant for this case. This is going to be, for anyone who is currently in my EMBA class, I'm going to repeat this statement, but all of us are busy professionals. Clinical care providers are very busy, constantly having to move between patients. And so they don't have a lot of time to maybe, casually review the latest research literature every evening. And so some of the newest innovations that are coming out in scientific research that might be relevant for care provision might easily be overlooked by a lot of clinical care providers. And so a tool that can sort of call it to their attention and say, the newest research says this, you might want to think about it or have a look at it, is a huge support for their clinical decision making. The second one, and maybe I should have put this first, since efficiency seems to be the primary focus or a major focus for a lot of organizations, is what is happening on that efficiency oriented front. As I noted, costs have continued to rise dramatically within the healthcare sector. So in an effort to rein that in and create greater productivity and efficiency, organizations have made a lot of recent moves. So one of those is workflow automation. So using the information technology, algorithmic tools to streamline workflows and say, what's the most effective way that we could go about the things that we do? And that means eliminating manually intensive tasks, labor-intensive manual tasks, things that have to be done on a repeated basis. If we can automate those things, it helps, again, the clinical care providers to really focus on the value-added elements of working with patients and addressing their needs, and eliminating what might be viewed as busy work, or work that is sort of the parts of our job that we least enjoy. We all, no matter what occupation any of you are in, you all have aspects of your job that you don't enjoy, and those are very often sort of the repetitive manual tasks. So if we can automate that, there's tremendous benefit. We also have the concept of optimized resource allocation. So this was a real realization during the COVID-19 pandemic. A lot of healthcare organizations, when the pandemic hit, discovered we don't have good processes for sort of managing our resources, staffing, knowing when we need to staff up for certain things. And so we can use tools to detect patterns that help us figure out, okay, what is our proper staffing? How do we use our resources most effectively? And sort of reframing our approach to resource allocation from something that's just based on intuition or prior experience to looking at hard data for pattern detection. And the upside of optimized resource allocation is also that it can make a huge improvement in terms of burnout. As I noted, certain categories, we've seen dramatic burnout, certainly in nursing. We've seen since the pandemic, we've seen high levels of burnout where people just get overwhelmed. And so if we could improve our ability to allocate resources, we can mitigate that burnout by making sure that people are properly supported and not getting overwhelmed on a regular basis in their care delivery. And also, when that happens, when that those overwhelming conditions occur, that's going to increase the likelihood of errors in the care provision. And so, if we can better allocate our resources, then we can reduce medical errors as well. And then we have AI-assisted triage and patient queuing. So I think the easiest way to visualize this or think about this is the case of the emergency room. When emergency rooms get overwhelmed, and the triaging of patients and sort of the queuing of patients can be quite challenging. You know, in an earlier era, it might have been looking out at the waiting room and say, you know, who do we have and who looks like they're in the most severe condition. But now with these tools, we can do that in a more systematic way and figure out how do we improve the flow of patients into and through the emergency room. Some of the adoption of this innovation, now obviously vendors, with almost every technology I highlight today, there is a universe of vendors who are offering solutions in that regard. And so vendors will offer many different claims, but the data that I've seen suggests at least a 50% reduction with a lot of these tools in wait times and significant increase. I don't have a percentage on top of my head in terms of patient outcomes overall, again, in ERs in particular. So getting people in and through. Oh, also providing, keeping patients informed. So I think all of us have had an experience where maybe we were in an emergency room or urgent care, and waiting is not pleasant, but some of the worst part of waiting is not knowing sort of where things stand or how soon you're going to get through or, you know, what is being processed. And so these tools can help keep the patients informed with, I'll allude to in a second, mobile apps that and patient portals can help keep patients informed about their status and how things are moving, which dramatically reduces the stress and psychological discomfort of those types of engagements. I'm going to pause for 1 second and see if there are any questions that have emerged so far. Noah, do we have questions that maybe we should talk through?
Yes. We've got one. Actually got two. From Kusan, development of smart devices with connection with healthcare. Would it be possible? Information about awards or grants for startups. Looks like trying to figure out if there's grants or funding available for these things.
So there's a lot of funding. Let's say prior to January of this year, I don't know where the funding picture stands right now. There was quite a bit of funding for innovations along that. So one of the things I'll allude to in a second is the impact of wearables. So wearable devices as a form of health monitoring has exploded exploded positively. The wearables, not themselves exploded, but the investment and innovation in that space has really grown dramatically. And lots of different funding streams. So obviously, National Institutes of Health has put a lot of support into the creation of innovative uses of sensing technologies and wearables. The National Science Foundation also here in the U.S. has done it. In terms of awards, I know that Gartner, the industry research group, every year does, and let me see if I have any of this in my notes, but I know Gartner does an award system for innovation in healthcare. And so people submit, I don't have it at my fingertips, but people submit their innovations and they get judged by a panel of experts, and it helps to actually call attention to some of the cool things that are happening all across the country.
And Professor Legeski was wondering why are record systems across healthcare services not talking to each other? And why are so many visits still requiring repeat info in pen and paper?
Yeah, so they do talk to each other. This is largely through an infrastructure called health information exchanges, which has gone from sort of rudimentary as hospital systems and private practices adopted those electronic health records. That interoperability was a big question because it was very low. You know, the ability to work across systems was a real challenge. And so what you saw across regions across the country was the adoption of health information exchanges. Here in the Western New York, in the Rochester area, we have something called the Rochester RIO. RIO is Regional Health Information Organization, or maybe it's Rochester Health Information Organization.
Yeah, I think it's
should go
Rochester.
check it.
Yeah.
Yeah. And so almost every region has a health information exchange like that, which basically exists to pull data from individual the systems of or get transmitted, receive data from the health systems or from the information systems of different health systems and hospitals and again private practices. That continues to be a big focus for continued development. Those have gotten much better. Interoperability has gotten much higher in most regions, but it continues to be an area of focus. So interoperability is a big bright shining area of focus in healthcare still, but it's gotten much better. So now if you go to a provider, again, I'm just going to use our regional systems here. If you were to go to a provider in the University of Rochester system and a separate provider, maybe a specialist who's in the Rochester Regional Health system, those are two different hospital systems. I believe they're both using the same EHR vendor, electronic health records vendor, which is a large firm out of Wisconsin, I think, called Epic. Your providers can get that data, can get access to that data. In terms of why there's still repeated tasks, there is still a need for continual focus on that workflow revision and that business process revision. So I think we will see that continue to decline, and it has declined quite a bit, but there's still plenty of room for improvement in that regard.
And we had one more get it here from Stan Press. So knowing that diagnoses can be difficult for complex or edge cases, what are the tools have been developed so far to help with more efficient diagnoses?
Yeah, so lots of AI tools in diagnosis. I think the challenge there, and some of those diagnostic tools actually show very high rates of accuracy. So I think I have this in one of the subsequent slides, so I might go on after this question. But in image analysis, so diagnostic imaging, whether it is X-rays, MRIs, brain scans, CT scans, you know, any diagnostic imaging, the ability to use artificial intelligence for that image analysis has gotten very advanced and accurate, to the degree that generally the tools can detect patterns, things like maybe malignancy in a image, where a human interpreter will struggle to do that. So in the subfield of radiology, AI diagnostics has become an enormous area of focus. I think one of the things I'll note is that we still want to maintain that human piece so that we don't over-rely on the technology and assume the technology is always right, because as you note, errors do still occur. And so we want to make sure with regard to any of the feedback from these tools, there's a human there to double check it, to see if it passes the smell test, to make sense out of it. And actually, with regard to some of the alert systems, that's a persistent issue with clinical care providers, where they say, there's this phrase, alert fatigue. I get so many alerts from the system that I start to ignore some of them because it's just the thing that I'm always going to get pinged with. And so I think ironing out that in these tools is going to be an important focus in the coming years, where we say, how do we fine tune these alerts and predictive models so that we are not inundating our clinical care providers with information that is not helpful, right? I think a big focus is making sure that that information is available, but there's a fine line between information being available and information creating overload. And so I think the fine tuning is going to continue to be an area of focus in the coming years.
And I think what an additional question from Kushan is you asked about the grants. Can the sharing of these devices for free after finishing it, but is there support available for these? I think that's what Kushan was asking.
Not sure I follow. Can I say this, Noah? Can you chat back and see if you can get a clarification? Because I'm not sure I follow the question, and then maybe we'll return to it in a little bit.
Yeah.
Okay. So diagnosis and care provision. The very next slide, I didn't even realize it. A lot of tools are being used to improve diagnoses, and again, this is also where the sensing of issues starts to emerge and the analysis of those issues. So when I talk about sensing, this is, as we just talked about, the introduction of wearable or implantable sensors that can help monitor patients and provide recommendations. Things as simple as an iPhone or an iWatch, sorry. Many of you probably wear an iWatch. The amount of health information that can collect just on your vital statistics is incredible. And there are more targeted wearables as well. So the ability to get that information without having a patient come into the office and wrap a blood pressure cuff around their arm is immensely powerful, right? And so doctors can actually have visibility into the status of their patients when they're outside of the normal care provision locations because of that technology. So the sensing and the input of those into the information systems is dramatic. We also obviously have seen for quite a while now the introduction of robots. I think we've probably all seen the videos of the Da Vinci surgical robots, which enable surgeons to engage surgery at a far more precise degree than a human hand is capable of. The old stories about Dr. Strange and things like that, where the steady hand of the physician or of a surgeon was this huge asset, and I'm sure that it is still a huge asset, but the introduction of robots makes that surgical precision even more advanced than that. We also have the introduction of robots for transport within healthcare provision, so you can have robots that will take supplies and medications and things like that to patients, and also robots even just for facility maintenance. How do we make sure that our facilities are pristine as we want our healthcare facilities to be? So just cleaning, disinfecting, things like that. Robotics can play a big role in that regard. On the analytics side, this is where the diagnostic and predictive and prescriptive analytics really come into play, where as I noted, with something like image analysis, the analyses and the diagnosis of illness and predictions about possible avenues of care and patient outcomes has gotten very advanced. So it really informs the physicians about the status of their patients at a level that the human eye is not always capable. And this is where computer vision advancements, which is a subset of artificial intelligence, has been really powerful and significant.
We had a couple more questions, Sean, and I think this one in particular is a good one. From Stan Press again, how can we help ensure protections from the AI tools to prioritize patient care versus the insurance company's preferences?
Yeah, so that's a great point. So I have my last slide is sort of some of the debates, and I think there's lots of debate in this space because it is this domain that touches all of us. We want to make sure that the primacy of the patient and the care and quality of care for the patient is coming first. In terms of the interaction between payers and providers, so payers meaning both insurance providers and governmental providers, so Centers for Medicare and Medicaid Services is more than 50%, I think, of the healthcare system is actually funded by CMS, not by individual insurance providers. That's a perennial issue because the incentives and priorities for payers and providers do not always align. I think with the adoption of a lot of these tools, there's perceived benefit for both sides of that equation, both the payers and the providers, because if we can improve the efficiency of provider organizations and improve the accuracy of diagnoses and more targeted or precise care provision, that's an efficiency benefit. And the insurance providers exist, any insurance provider is by its nature a pooler of risk. So insurance exists to pool and to measure and cost risk. And so if we can bring down that risk through more targeted care provision, there's benefit for both. But I think that is one of those where, traditionally there are regulatory solutions to try to create and enforce the balance between the payer and provider sides of the equation. But I think in terms of ensuring the primacy of the patient, that's where provider organizations, that is a primary focus of provider organizations. And I think they have to continue to emphasize that in their own investments. Insurance providers expect certain types of information, but the care providers are also managing internally to improve their own efficiency with a focus on quality of care. How do we improve patient outcomes? And so I think that is an advocacy role for provider organizations in particular, not to suggest or emphasize the antagonistic dynamics between payers and providers, but certainly I think provider organizations have to continue to make sure that that is a primary emphasis as new tools are adopted and applied. Another area of focus, and then we can have wide-ranging discussion in a second, is expanding access, right? How do we make sure that access to care is available to as broad a population as possible? This is, of course, has always been an issue with things like rural areas where, if you have to travel several miles to the nearest hospital, that's a challenge. If you're in an area that has physical impediments, or one of the things I studied many years ago was the adoption of telemedicine or telehealth in the care of nursing home patients, where they would have to travel an hour to get to the nearest hospital that had the type of care that they needed. And for nursing home patients, sometimes a transport of an hour is not a trivial undertaking. And so how do we expand that care? Lots of innovations in this space. One is telehealth in general. So having virtual remote conversations with care providers. This has existed. So it used to be called telemedicine. I think telehealth is the more encompassing label that is more popular now. But telemedicine has been around for 30 plus years. So the innovation is actually quite old. And there had been a large push for how do we get more adoption of telemedicine services for a long time without much traction, right? So a couple areas you saw in a couple subfields where there was some adoption. So telepsychiatry, where you have virtual conversation, consultations with a psychiatrist or psychiatric care provider. Telestroke actually is one that was adopted fairly early because you could have a stroke specialist engaged. Stroke care is very time sensitive. If a person has a stroke, if they can get into care within 4 hours, their prognosis is incredibly favorable. If it's more than 4 hours, that prognosis declines dramatically. And so again, a couple of these areas were adopted to some degree early, but the pandemic was actually a catalyst. So during the COVID-19 pandemic, you saw widespread adoption of telemedicine and remote consultation, and that has now persisted. So far be it from me to suggest some beneficial outcome from the pandemic, but the option of telehealth and remote consultation has persisted since the pandemic, because I think a lot of, similar to online learning, a lot of professionals in the space didn't have a lot of experience with it until the pandemic. And then all of a sudden they had no option but to get experience with it. And once they had that experience, then they felt confident continuing to offer patients that option going forward. And so it was a real catalyst for adoption of telehealth. The implementation of patient portals and mobile apps has really made patients active participants in their own care and enabling, support and interaction. Oh, I have a typo there. That's geographic and temporal flexibility. Support and interaction outside of traditional, co-located consultations. And again, getting back to this idea of the wearables, we now have a lot of opportunities for remote monitoring, which means that information gathering and care provision can move outside of just traditional location-based activity.
Sean, can we get into another question in and around massive data sets, right? So
you guys are predicting my next slide every single time,
Okay.
but go ahead.
Yeah. Well, Japinder was wondering, he's a software professional, so if an example here, if an insurance company can reduce individual healthcare premiums by using data from an Apple Watch, exercise data, if you get 3 complete rings, for 20 days a month, you save money. So he'd like to hear your thoughts, on AI, being used in massive data sets to optimize, the particular global U.S. system, U.S. health.
Yeah, I think the potential for that type of, again, if an insurance provider exists to measure and pool and cost risk, the more information they have, the better they can do that, right? And so that type of remote monitoring provides a ton of information, and so they should be able to really fine tune their own costing and efficiency. The issue that comes up there is specific to privacy. So I'm going to use a corollary case. So not in health insurance, but in automotive insurance. Many of you might have access to what's called usage-based insurance. And this is where your auto insurance provider says, you'll get a discount. We'll give you a discount, 25% discount on your premiums if you share your driving behavior with us. In some countries, that is required. So, for example, if you wanted to get auto insurance in Italy, you have to agree to share your information with the insurance provider. In the United States, that is an opt-in situation. And I use this example frequently when I teach classes because I think it's kind of an interesting one, because I'll say to my class, okay, how many of you would be interested in that program? And, a minority of the participants will usually raise their hand. And I said, as an insurance provider, what does that tell me? It tells me something incredibly valuable. Number one, it tells me who are likely the most safe drivers. And so if I can get more of those people to opt in, that's a huge benefit to me. If I'm costing and estimating and pooling risk, and I can get people who tend to represent lower risk, that's a huge benefit. And so I do think the sharing of that type of information could be valuable. There is a privacy question, though. I think a lot of people would say, I'm not going to share this information about myself with my health insurance provider because, if I happen to go on maybe a bender's not the right word, but, I eat a couple cheeseburgers in a day and somehow that's recorded on this device, is my health insurance provider going to send me a text later in the day saying, hey, cut back on the red meat, buddy? Fatty. I'm using myself as an example here. I think a lot of people would be very uncomfortable with giving that degree of visibility to insurance providers. So I think the opt-in conditions are really key questions here. I think there's absolutely that potential, but I think regulatory guidelines would still need to be created. Our law always trails our ethical reasoning as a society. And so I think a lot of questions would remain open there, but a lot of those turn around this question of privacy.
If I could weave in Professor Legeski's question here as well with
I'm going to go to the next slide, but I'm still listening. Go ahead.
Okay, prediction, right? AI predicting He was wondering about, do you see AI predicting health at retirement based on someone's current health and lifestyle to provide opportunities for change today?
So, not specifically at retirement, at least I haven't encountered it. I'm sure it's out there. Um, I think the AI can do good predictions on long-term prognosis based on health factors, and can provide a lot of feedback on, okay, based on your profile, either things are looking great, keep doing, keep going to the gym and all that, or this is what your health situation might look a couple of years from now. And so I think that gives care providers a great resource to sort of educate patients on, and actually engage patients in their own health journey, so that they're fully informed about sort of where the trajectory is leading. I haven't seen that specific to retirement, but again, I'm sure that that possibility exists. Okay, I'm going to keep going just to keep us on pace, but I promise I'm almost done. So the piece that is not really patient-facing, but is important for investments in health IT, is the question of data infrastructure, because all these tools that we've been talking about, the power of analytics is dependent on the data to which it's applied, right? And so you can have a super powerful analytical engine, but if you have a tiny data set, it's not much value, right? It's not giving you value, because the value of the analytics is in the detection of patterns, and the larger the data set, the more insightful the patterns are that can emerge from it. And so all of the things that I've talked about so far imply the capture and use of way more data than we were capturing and using before. And that has caused a shift in this sort of data infrastructure for a lot of healthcare organizations. In particular, what you've seen is a strong cloud migration. For a long time, healthcare providers resisted migrating to cloud infrastructure, meaning the internet, right? Meaning machines that aren't housed, that aren't maintained on site by the organization itself, but are provided by data providers, right? Cloud providers. And that resistance, I think, was driven by concerns over privacy and the sensitivity of the data. We have some of the most sensitive data about people's lives in our possession. How do we make sure we're protecting that? And so I think a lot of healthcare organizations said it would be irresponsible and a breaking of the physician-client confidentiality and the patient, our fiduciary responsibility of the patient to house that offsite. I think the data demands that all these technologies have created has made a lot of organizations realize there's just no way to do it unless we tap into scalable cloud resources. And so you've seen a massive move to move EHR systems to a cloud infrastructure, so getting them off of installed base. You've also seen this move to what's called edge computing. Edge computing just means completing information processing closer to the source where it's being done. So if we can use Internet of Things, that's what IoT is there. I probably shouldn't have used an acronym without spelling it out. Internet of Things device, meaning internet connected, non-traditional computing devices like various types of sensors or medical devices. So if we can actually have the computational processing done there, rather than being transmitted back to a server, having the server process the data and then transmit it back to a care provider, the latency reduction, the time it takes to do that analysis goes dramatically down. So you've seen this big move to edge computing, which does raise questions about security and has to be reinforced, but a huge move toward cloud, edge computing with a lot of these healthcare technologies. I alluded to health information exchanges earlier. That continues to be a big area of focus. So you've seen growth in the health information exchanges and the robustness of their infrastructure. Again, those are not organization specific. They tend to be regionally specific, funded by both insurance providers and care providers, organizations. And lastly, you've seen a lot of emphasis in recent years on the adoption of blockchain technology to protect data privacy and security. Blockchain is the distributed ledger system upon which Bitcoin was developed. But after Bitcoin became a big thing, a lot of people said, aside from just the cryptocurrency, this ability to capture and to capture information and transactional information in a secure way that doesn't require some third party to legitimate it is really valuable. And so you've seen adoption of blockchain technology for the transmitting of health data in a secure and private way, and lots of other industries, supply chain management. It's also been a massive focus in recent years. So the actual ways in which we work with data have changed dramatically and continue to be a big area of focus because, again, healthcare organizations have come to this realization that we can't do this based on the machines in the basement. Also, just as a side note, ransomware attacks, hospital systems were for a long time one of the primary targets of ransomware attacks. And you can understand why that's the case, because if a ransomware attack hits a hospital system and they have all their data locked up, it's a matter of life and death to get that data unlocked. And so the malicious actors who were launching those attacks said, well, here we got somebody who, if we lock up their data, they'll pay any price to get it opened up again. And so healthcare systems were a big target for those malicious actors. And I think that's been one of the other reasons for this cloud migration, because cloud data has better backup that's in place ahead of time to make sure that we can't be put in that vulnerable position. Okay, on the debate side, again, I think lots of debates with all this thing because of these massive investments and the way in which this system touches everything that we do. Lots of concerns, ethical questions that have been raised. Privacy and data security is probably the biggest one, as we're collecting all this vast amounts of data. How do we make sure that it is safely and privately collected, stored, and used? The potential for algorithmic bias. So algorithms are only as good as the data they're trained on. And if we train them on data that has bias embedded within it, then that bias can be promulgated through the recommendations of the system. A non-healthcare example of this, there was the tool that I think Google's early version of a camera did so that it would take the picture when everyone is smiling and when their eyes are open. It had a fundamental flaw. It was trained almost entirely on Caucasian images. And so it would not take pictures with Asian participants because it wasn't recognizing an Asian eye as open because it was trained on Caucasians, right? That's bias. That's bias embedded within the algorithm. And so the same thing applies here. If we're making predictions and diagnoses and improving our care provision, but the training data isn't representative of the entire population of patients that it needs to be, then that bias can be, again, promulgated and actually do great harm. So big concern, big area of focus, making sure that we're building on representative data sets. And lastly, here is this concern over reliance. Does this use of artificial intelligence tools and algorithmic tools start to encroach on the autonomy of physicians in decision-making, where physicians don't feel that they can make what they, based on their clinical judgment, is the appropriate course of, set the appropriate course of action for a patient, and also on patients. We want to make sure that patients aren't sort of constrained to, in ways that violate their autonomy, to recommendations coming out of these tools. So lots of issues persist, and I think those will have to be a continual focus as new technologies are adopted and used. Okay, that's it. So let me stop this and see if in our last couple minutes, if we have additional questions. Happy to talk through any that you have. You're muted, Noah.
I don't see any more questions. Jancy, do you see anything else in the chat?
No, nothing's popped up on my side, but
Any good comments that we should add? I see one here.
Yes.
Telemedicine El Salvador and Google are collaborating on a telemedicine platform for using AI to improve healthcare access and streamline processes. Yeah, that's a great example. So, you know, I, in my own work, tend to be very US focused. And there are plenty of challenges to access in the US, in specific neighborhoods, again, in rural areas. But at a global level, those challenges are often augmented significantly. So using telemedicine or telehealth to expand that access, I think, has a lot of potential and important benefits at a broad societal level. is anyone, since I closed with issues and debates, do the innovations that I've highlighted here, well, maybe this will be the poll, if you could type it. Do the innovations here tend to excite or tend to raise concerns? You got to choose just one, right? Either it makes you intrigued and excited about the potential for improving healthcare delivery, or it makes you uneasy, maybe about privacy or algorithmic bias. You don't have to put all that in there, Jancy.
No, I was doing the very short version.
Yeah, that's okay. Do the abbreviated version.
Making sure I'm spelling correctly.
So Robin Flaherty just asked what your opinion is on who you believe owns the healthcare data, and should the consumer be paid for the data that is used?
Yeah, it's a good question. That question of ownership, I think, is not entirely resolved, because ultimately information about the individual should be owned by the individual. But again, it does make its way into broader data sets that can be analyzed by the entire healthcare system. The paid for the data is a little tricky, because my gut feeling there is if we're talking about technologies that can improve your healthcare and the care that is provided to you, there's a compensation there, right? So I certainly think opt-in has to be the default option, and maybe that reflects my own Western ethical framework. But I think lack of informed consent raises big ethical flags. So opt-in defaults should be the priority for the sharing of any of this record information, which it is currently in the healthcare system. But if you see expanded use of wearables and data collection, even the conditions of opting in become a little challenging, because all of us have probably installed a piece of software and gotten the user agreement that comes up at the beginning and immediately scrolled to the bottom without reading more than 3 words and agreed, right? And that's a form of opting in, but it's not necessarily true to the preference for informed consent. Are you really informed if the software provider knows you're not going to read the agreement? When you use Google or Gmail, Google owns your mail. Do people realize that? I think most people probably don't realize that they own the content of your email if you're using Gmail. So it's a good debate. I don't know about necessarily paying the sources of the information if they're opting into it, provided that it is being used to improve the quality of care that they're receiving.
We got about a minute left, but back to the insurance. Stan Press was wondering if AI is actually going to reduce costs to patients versus create more margins for the insurance providers.
So this came up in a discussion I had recently following the what to my mind was horrific assassination of the head of the
United Healthcare.
United Health. Yeah, I was going to say Universal Health. United Healthcare. Healthcare insurance. I mean, there's lots of sources of cost within our healthcare system. I think it would be inaccurate to say the insurance providers are the primary source of cost and inefficiency. Healthcare insurance providers tend to have fairly narrow margins. That doesn't mean that perverse incentives can't be created, but the margins for insurance providers do not tend to be high, because if all of a sudden if we see this great improvement in efficiency and the ability to bring down costs across the healthcare system, and insurance providers aren't converting that into their pricing of risk, there is a competition between healthcare providers, right? Or sorry, between insurance providers, and hopefully that competition. And maybe I'm overly optimistic about the dynamics of a free market, but I think that efficiency should play out in the competition between healthcare providers. Not that we shouldn't continue to focus on it, but I'm maybe a little more sanguine than Stan is on the potential there. What were our results, Jancy, in our last, I know we're over.
We have a very excited group of people, but at least two
Yeah.
people are concerned.
We need both those groups of people, I think.
Yes.
I think anytime you have big innovation, we need people who are excited and wanting to drive things forward. And then we also need the people who say, wait. Let's make sure we're thinking through this, particularly for something that has such a broad societal impact.
Absolutely. Well,
Great. I'm sorry I ran a little long, but I
You were
appreciate
great.
all the questions and comments from the participants.
It was a very engaging group, and thank you all for logging on today. And Sean, thank you again for making the time to share all your great insights. And for those who are still with us, I did share some links in the chat. So if you wanted to catch more executive insights, you can find that on our page, and this recording will be there soon, but I'll be sending access to this recording to everybody here today shortly. And if you want to dive even deeper, specifically with some of Sean Hansen's insights, he has a great podcast, The Management Lab, with some amazing episodes on AI's multifaceted application in multiple industries, as well as some great discussions on organizational behavior. So thank you again, everyone, for attending, and stay tuned for the next one.
Thanks, everybody.